Hi, I'm here with Sara Bigi. Hi, Sara.
Hello, Maria Grazia.
Let me start by introducing you. So, Sara received her PhD in linguistics from the Università Cattolica del Sacro Cuore di Milano in Italy. Since 2008, she conducts research on doctor-patient dialogues in different clinical settings, mainly in the field of chronic care. Her main research is concerned with the analysis of the structure and functions of argumentative discourse within medical consultations. In this area, she has analyzed the argument from authority and different argument types used by doctors. Sara's most relevant research analyzes consultations as activity types, identifying and describing the various discourse types that contribute to their development. Sara is the co-chair of PEACH, a committee within each International Association for Communication in Healthcare, aimed at favoring the translation of knowledge on quality communication in healthcare from academia to practice and policy. Today, Sara is going to give a talk titled Assessing the Quality of Shared Decision Making, Challenges and a Proposal. Sara, the floor is yours.
Thank you, Maria Grazia. I'm very happy to be here and to participate in this conference, and I really appreciate the way you worked around the challenges posed by this pandemic. So I'm sure it will be a very interesting interaction later on. So my presentation today is, of course, focused on shared decision making, but on a specific aspect of this process, which is the assessment of shared decision making. I come to shared decision making from my interest in discourse analysis, dialogue analysis, I should say, and argumentation theory. So I am particularly interested in observing the process of decision making and also trying to discuss if and how we can assess its quality. As for the challenges of shared decision making, I don't think I will talk too much about them because our keynote speakers have actually discussed these issues quite at length and in a very interesting way too. So I would just show these references that are the ones I found most interesting. Of course, there are many more. For example, also the paper Professor Sarangi was referring to by Loris Kaldian, which appeared in Communication and Medicine 2017, which should go in this list because it is also a very interesting contribution to this debate. Like I said, I will not talk at all at this point about the challenges connected to this idea of this concept of shared decision making. I would just say that decision making being a communicative act, I think it is important, if we want to understand it thoroughly and to also foster its implementation, if we believe that it is worth implementing it, that we really understand what decision making is made of in dialogical terms, in communicative terms. Also, this idea of sharing, as our keynote speakers very nicely discussed, is sort of slippery. It's not very clear all of the times who should be sharing what and when is it right or is it appropriate that, for example, patients share, have a part in the decision, or when regarding to which topics they should be included in the decision. So there is, in this discussion about the assessment of decision making, I would like to start with by referring to a paper by Elwin and Mirenschatz, which actually develops this a very nice discussion about how is it possible to assess the quality of decision making. I think the most interesting point, the two most interesting points that they make are, first of all, the fact that the first point is when they say that in order to assess decision making, it is probably not optimal to refer to the outcomes of the decision making process. This is because it's very clear to those of us who study communication and interaction, because it's very difficult to draw a direct line between a communicative act and its outcomes. There are so many factors that can impact on the outcome. But then, is it impossible to evaluate the quality of a communicative act? No, it isn't. And this is the second very interesting point that the authors make. They distinguish between the process of deliberation, which leads to the decision itself, which they call the determination. And I think this is a first interesting and useful also distinction, because it allows us to focus on the process of deliberation and to look at it as a dialogical process. So from now on, when I talk about deliberation, I am referring to what otherwise we have called so far as decision making, but which should be shared, as we say, in the consultation, but in any case, the decision making process. Elwin and Mirenschatz identify these 6 points that you see in the table as the components, we could say, of deliberation. So they're information search, knowledge gain, appraisal of knowledge sufficiency, imagining counterfactuals, effective forecasting, and preference construction. These steps, let's say, these components are interesting also from another point of view, because they, in some of them in particular, are similar to the components that have been identified by a scholar who has been very active in the field of argumentation theory, and who has proposed a model of a deliberation dialogue. This is the model that I am showing, and it helps us take a first step towards understanding what a decision is made of. This is a particularly useful model, I find, because it distinguishes very well which are the components, the stages, as he calls them, of the deliberation. So what you are looking at right now should not be understood as a representation of a whole consultation, but only of the deliberation phases, let's say. So in this model, the deliberation is made of an opening stage where the issue is set. And what issue is set? A deliberation, a decision, a process of deliberation is always aimed at finding a solution to a problem, or in any case, agreeing on an action, a course of action that is considered necessary in order to advance in a situation or, again, solve a problem. So in this opening stage, the issue is set, and there is acknowledgement as to the fact that a choice needs to be made. So the circumstances that have to do with this problem, with this situation, are retrieved, and they are sort of laid out. From the opening stage, the participants then shift to an argumentation stage. And this is the part that I will focus on mainly. because I find it particularly interesting and relevant, above all because it has not been described very much in the field of healthcare communication. In the argumentation stage, what the participants do is they put forward proposals for action, and they either object or discuss or revise their own proposals until they come to a closing stage where a proposal that is considered best, the best one, is agreed upon. Proposals in this model can serve two functions. They can initiate an argumentation sequence. So I'll just go back shortly. Passing from the opening stage to the argumentation stage, this passage can be done by one of the participants putting forward a proposal. So I give you two examples that I take from a corpus of video recordings of consultations in a diabetes outpatient clinic that I collected a few years ago. These are simple translations. They were collected in Italy, so the originals are in Italian. And they are taken from two different consultations. In the first one, the doctor is has considered all the exams of the patient, the clinical, let's say the clinical information. And so she comes to sort of a conclusion and she says, so from my point of view, I do not have much to suggest, mainly because I do not have enough room for therapy. You are already undergoing a very significant therapy, so if the three levels of the treatment are physical activity, diet, and drug, the quantity of drug prescribed is already very high. Therefore, we should work on the other two levels. If only one of them, both, or a little of both, is something you need to tell me. How do you think you could manage it? So, first of all, the doctor says we should work on the other two levels. So this is sort of setting the paradigms of the possible options and of the topics of discussion. We need to discuss on how to improve your situation and what are the relevant topics to discuss. Whether you can manage to work on physical activity or on diet. How do you think you could manage? And with this question, the doctor shifts to the argumentation stage by suggesting that it is the patient who should start putting forward proposals. In the second case, the doctor states an actual proposal. The situation is slightly different. There is a patient here who has admitted to drinking Coke, and Coke is not very good for someone with diabetes. So the doctor says, I wouldn't recommend it to you. If you really want, you can have Diet Coke. And this proposal for change triggers the shift to the argumentation stage, to the stage or sequence. In another, the other function that proposals perform in this model is to actually develop the argumentation sequence. So they are the speech acts really that allow the argumentation stage to move forward. And here are other three examples taken from the same corpus. The first one is the same patient from the first example we had before. She's there with her adult daughter, and the daughter says, Mom, would you like to go to the gym with me for 3 months? And she says, let's go, let's try it. So this is a proposal. The doctor had suggested, I think, a change in diet, but also that it would be good for her to move more. And so the daughter puts forward this proposal. The same patient in another, at another stage of the consultation says, I can do without sweets, but not without fruit. And this is another proposal that helps the the deliberation process move forward. Proposals are also, in some cases, at the same time, a way of introducing new information in the consultation, in the deliberation. Maybe the doctor didn't know that this particular patient was very fond of fruit. Now she knows it, and she can adapt her counter proposal if she has one. And the last one is again from the consultation where example number 2 previously was taken from. Again, the doctor says during the deliberation, during the argumentation phase, wine with Coke, she finds out that this patient not only drinks Coke, but drinks Coke mixed with wine, which is even worse. So she says, I really would not recommend it. Why don't you choose? Have one or the other. And in this way, they end up coming to a sort of an agreement where the patient accepts to drink water, basically. So in consideration of the characteristics of this model, my proposal, which is also a sort of a research question actually at this point, is to consider whether this model of the deliberation dialogue could be used as an assessment tool. Because once we have looked into the deliberation process, then of course, like I was saying at the beginning, it becomes interesting to understand if we can evaluate it, if we can assess its quality, especially in view of implementation, because then it's possible to identify indicators, for example, or action items for both clinicians and patients to improve the way they decide together. So I was part of 2 experiments, we can call them like this. And the first one in the, let's say, conducted on a corpus of consultations collected in a hemophilia context. And the second one instead conducted on a corpus collected in the context of assisted reproductive technology. So the first one, here in hemophilia, the main problem that doctors face is patients' adherence to therapy and healthy lifestyles. Hemophilia is a chronic disease, so it brings along all the challenges of chronic conditions, long-term adherence, the need to change one's lifestyles and habits, which is always very difficult. And in this case, in these conditions, it is very important that patients are always motivated. Every time, let's say, it's important to find new motivation to adhere to treatment and to, let's say, keep going. Not let go of the therapy, of the healthy habits, and so on. So the aim in our study was to apply the model of deliberation dialogue with the hypothesis that it could work as a sort of golden standard to identify misalignments and potential causes for suboptimal realizations of deliberation. So we are assuming sort of that this model represents the best way to conduct a deliberation, and what we did was we went looking for the same realization of deliberations in our corpus, with the implication that the criteria to assess quality of deliberation at this point are the presence or the absence of all the stages of deliberation, as in the model. What we found was that out of 43 deliberation sequences, 22 were complete and 21 were incomplete. And participants were not always equally contributing to deliberation. So half of the deliberation sequences that we found were let's say, suboptimal realizations of deliberation. When I say incomplete, I mean that either the opening or the closing stage were missing, or that the argumentation stage was not optimally realized, mainly because not all the participants were actually participating as they should have. So sometimes doctors were not putting forward proposals, but they were sort of not dismissing patients' proposals, but maybe not really following up on them. Most of the times, patients were not putting forward proposals, but it was not very clear whether they agreed with the doctors or if they were simply providing a signal of uptake, but we don't know what they were really thinking. So our idea was to find out if the model could be used as an assessment tool. So after a while, we had the opportunity to, and so far, it looked like it could be used as an assessment tool, of course, with these limitations, because to describe the presence or absence of the stages does not say everything there is to say on decision making, but it does say something in terms of, let's say, good realization of deliberation. Sometime later, we had the opportunity to look at parts of a larger corpus of, again, video recorded consultations in the context of assisted reproductive technology. The corpus was collected by, in both cases, the corpus was collected by our colleagues from the San Paolo Hospital in Milan, with Elena Vegni where Elena Vegni is the director, the coordinator of the group of clinical psychology. The main problem for doctors, one of the main problems that refers to communication in assisted reproductive technology are high levels of stress, dissatisfaction, and discontinuation of treatments. Of course, these problems are also due to the low rate of success of these techniques, of these treatments. But many patients also report some dissatisfaction with the communication style of clinicians. So it seemed to make sense to analyze more in detail the communication style of clinicians. The analysis of this corpus is in progress, but in this specific study, we thought it would make sense to replicate the analysis conducted in the previous study on this different clinical context. Again, to assess the quality of deliberation by verifying the presence or absence of all the stages in the deliberation, in the model of the deliberation dialogue. It seemed also interesting to sort of compare these two clinical contexts, which of course are very, very different. I mean, one is chronic care, the other one is not, and there's so many different aspects. But we were also trying to see if this tool that we were testing would work across contexts. So we analyzed 20 transcripts of couple-doctor interactions in ART, and we found that all phases of the deliberation were always present, and all participants had a chance to contribute. So actually, the results were very, very different. We had a very sort of difficult realization of deliberation in haemophilia. We have close to perfect realization of deliberations in this setting. So if we compare the two situations, in hemophilia, decisions that are related to treatment or lifestyle have to be made very frequently. Almost at every visit, there is it becomes necessary to make slight changes in the treatment, or it becomes necessary to ask patients to reconsider their diet or their physical activity. This is because, like we said before, hemophilia is a chronic condition. It goes on for all the patients have to live with it all their lives, and of course it changes as the life conditions of patients change. And so every time it is necessary to rebalance, so to say, treatment or lifestyles or habits. In assisted reproductive technology context instead, when the couples come to the encounters, at least from our data, the most difficult decision has already been made. They want to try an ART treatment. This is not something that is discussed in the consultation at the point of the encounter. Doubts or second thoughts might come up, but they are not thoroughly discussed in that moment. Second point, the available options in hemophilia can depend on patients' preferences or changes in patients' life conditions or health. So in other words, the available options largely depend on the patient's situation. On the other side, the available options, and when I say available options, I mean what is possible, what are the possible ways to go, the possible courses of action that the participants can deliberate on, can discuss about, depend on the seriousness of infertility, on the age of the couple, on boundaries set by legislation, on costs of treatments. So these are all factors that are external, so to say, that are not under the control of the people involved, at least in part. The costs of treatments, for example, of course, can be controlled, not the cost, but some people may have the opportunity to invest more money than others, and in that case, that is something that can be dealt with. But in other cases, you can't change your age, you can't change a law, you can't change the seriousness of your infertility. In hemophilia, deliberations are often difficult because patients resist to change of treatments or change of habits. On the other side, deliberations are highly cooperative because couples are willing to do everything possible to reach their goal. They almost never discuss the proposals, the doctor's suggestions. On the contrary, sometimes they even go to the point of suggesting almost unethical courses of action because they are so eager to achieve their goal. In hemophilia, the most difficult deliberations have to do with decisions about lifestyle changes. In ART, the most elaborate deliberations often occur about hypothetical scenarios. So they start discussing about what would I do if, for example, I produced more ovocytes than necessary, or if I had 3 twins. They are very projected in the future. While in hemophilia, they're dealing with very practical and pressing, let's say, conditions that they have to come to terms with. So what do we learn from these studies and from the comparison between them? Well, first of all, I would say that the model of the deliberation dialogue actually proves to be a useful tool to analyze the deliberation process and at least assess its completeness. Is this particularly relevant? I think it is, because especially when we notice that the argumentation stage is incomplete, or that the closing stage is not present, these are factors that can be easily turned into recommendations for both for clinicians and patients in terms of tips, for example, to make sure that process is improved upon, and to make the participants more aware of what they are doing with their communicative acts. Of course, other tools are needed to analyze, for example, the validity of the arguments used by the participants, or any other communicative strategy used by the participants. So, of course, this model is not, like I already said, is not considered by anybody the solution to all the assessment challenges for decision making, but at least it does provide a first way of describing this process. The other point that I think is important and is also very much in line with what the keynote speakers were highlighting is that the relevance of deliberation depends on the characteristics of each specific clinical context. So, and this is to say that, of course, ethically speaking, it is always important that all the participants in these interactions in the medical context have a chance to voice their understanding of health, what they consider well-being, what their priorities are. Even in end-of-life consultations, this becomes so important when one may value a shorter life, but a life, let's say the last days of your life, maybe less, but they qualitatively, you want them to be richer. And so this is a priority that you can express, or you should be able to express. So for sure, we all agree that this is something that is important. But in the practical examples, we see, in real life examples, we see that when I say the relevance of deliberation, I mean to say that perhaps the quality of deliberation itself is not such an issue in the same way in all clinical contexts. So for sure, in chronic care, it is important because making decisions is important because those decisions have to be then enacted by the patients. And if the patients are not on board, they will probably not do what should be done, and their health will not improve or will worsen. In other contexts, such as, for example, ART, the real challenges have nothing to do with how deliberation is performed. So it's always interesting to go and look at how deliberation is performed. But then there we realized that that was not the point. That was not the issue. The real challenges in this context are, for example, the two that I am listing there, the ones that we found in our corpus. For example, the challenge of dealing with the tyranny of time and the arbitrariness of nature. And what I'm referring to here is the problem with age. The tyranny of time is that. and the arbitrariness of nature, because some people cannot conceive and others can, and this is not something that can be, there is not a criterion there. It's arbitrary, and sometimes there is nothing to do about it. And this is a point, this is in many cases, this was from a dialogical point of view, this was a point of real difficulty in the development of the interaction. The other difficulty was dealing with legal or technical boundaries set to the possibilities of ART. So it was the case in a few examples that there might have been the possibility of trying a treatment, but laws or ethical principles would not allow doctors to propose these treatments to the couple. Of course, these 2 points, these 2 challenges, could be explored with other tools offered by argumentation theory, but they don't necessarily have to do with the quality of deliberation. So I come to the conclusion of my talk by suggesting a prompt for discussion. So every time we discuss about decision-making and shared decision-making in the clinical context, we end up reading or saying that there is always this big gap between research on shared decision-making and the clinical practice. Actually, the debate that we are conducting in this conference and all the papers that have been cited really shows that that thinking about shared decision-making is progressing and is very deep, is very well developed, very interesting. But somehow then we always notice this big distance between research and the practice. And of course, this is a point of view, so I hope maybe it can be taken up during the discussion. I think there is one very big challenge, one very big issue here, that is the lack of structured education in the humanities for medical students. I think this is what could fill this gap. And by structured education, I mean a structured, well-organized, a complete component, a humanities component in the curriculum of medical students. But the problem I see here is that until the healthcare system does not value communication in healthcare as a proper medical act, just like prescribing or diagnosing, nobody will think there is an incentive to educate medical students in these areas of humanities or to implement it in the clinical practice after all. Because as it is structured, the system probably does not leave time, does not value the effort of conducting deep and sometimes very difficult and very delicate dialogues with patients. So I'd be interested to hear different opinions on this. I think I've come to the end of my talk, and I thank you very much for your attention.